Let's go to the blood flow, heart sounds, and the cardiac cycle. Cardiac cycle is one complete contraction and relaxation, which involves the four chambers. Cardiac cycle involves the atria and the ventricles. Two main variables govern fluid movement. Pressure causes flow and resistance opposes it. Flows from high pressure point to low pressure point, and the pressure is measured in millimeter mercury with a sphygmomanometer. This syringe shows you that at a given time you have a certain volume and pressure. If you pull on the syringe, you will then increase the volume inside the syringe. If you pull on the plunger, you will increase the volume inside the syringe. The pressure will decrease. So also decreases the pressure. In fact, it decreases the pressure so much that it becomes a negative pressure. In fact, this will suck in air. If you push the syringe, the plunger forward, you actually decrease the volume. Original volume. So the pressure will increase. So when the volume decreases, the pressure increases. Slide. When pressure falls, if the mitral valve is open, the blood flows into the left ventricle. When the ventricle contracts, the AV valve is closed on top, the mitral valve, and it will at a certain point open the aortic valve, and the blood will flow into the aorta. The opening and closing of the valve are governed by pressure changes. If the valve is limp or weak, it is when the ventricles are relaxed. But it can also become a problem if it leaks blood. Okay? So here's a picture, and I will actually first refer to this. Let's see if there's another face here. It says here the phases of cardiac cycle. Phases of the cardiac cycle, okay? Ventricular filling of the ventricles, and you can only do this if the ventricles are not contracting, obviously. So when they're not contracting, they are in relaxation. They are in diastole. Then the next is isovolumetric contraction, which means the volume doesn't change, right? Nothing comes in, nothing comes out, and then there's contraction. So what happens? The pressure will build up. Next step is release the blood. There's ejection. And of course, that happens because the ventricles are contracting. They are in. Isovolumetric contraction is also in systole. Now, after pushing the volume of blood out, the blood itself in the vessels will fall back and close the valves behind them. So you again have a closed situation, isovolumetric relaxation. This whole four steps can be completed in less than a second. In less than a second. In one Mississippi, your heart beats and makes a sound. The sound is lub dub, lub dub, lub dub, lub dub. Okay, you can listen to the stethoscope and hear that. But imagine it again. Lub dub, lub dub. That's almost less than a second. One Mississippi, one Mississippi. And if it's fast enough, lub dub, it's actually less than a second. Remember that because I will describe the love dub. I will describe how that love is made and the dub is made. And this is very important. If you know this, you can talk with any medical personnel and understand what's happening. Okay, so follow closely. Let's go to this ventricular filling, huh? The first step is that the ventricles have just contracted, and so therefore they are open, they are relaxed. Okay, when they contracted, the atrium above does not get involved. It's all about the ventricles. At the same time that they're not getting involved, they are actually filled with blood from the superior and inferior vena cava, and the left atrium is filling up because of the pulmonary veins coming from the lung. Okay, so when the ventricles have just contracted, they are now open, less pressure in them. This is the time of ventricular filling, the first stage or phase. The ventricles expand and their pressure drops because the volume expands, and if the volume expands, pressure is inversely proportional, pressure drops, which means they are open for something of a bigger pressure. And the bigger pressure is that of the atria above. So the AV valves, the valves between the atria and the ventricles, are now going to open because there's more pressure in the atrium because of the blood has been collected. Okay? And when it falls down, it will fall into the waiting ventricles. So the right atrium will open up the AV valves, and the blood from the right atrium will drop into the right ventricle. The blood from the left atrium will drop into the left ventricle. That first load, okay, is called the rapid ventricular filling, or the first of the first one third. Rapid ventricular filling because it okay. All right, so naturally it will fall down on the ventricles. The ventricles collect them. But you should realize that blood is continuously flowing from the superior vena cava and the inferior vena cava. So here's some more blood flowing in. And there's no valve between the vena cava and the atrium that would stop that. So when the AV valves is open, it will continue into the ventricles. Same thing on the left side, right? So this is your diastasis or second of the filling. This is slow fill because it's just trickling in, right? It's continuously going into the atrium. Therefore, it continuously flow into the ventricle. Now, the last part that would fill these ventricles is when the SA node starts to fire. Okay, the SA node starts to fire, and therefore will contract the atrium, both right and left atrium. Huh? When the right and left atrium contracts, it will push the last third of the blood forcefully into the ventricles. The ventricles at this time is almost filled up, almost to the rim. It's just like a suitcase that's all filled with clothes, and you remember you got 5 jeans to still put in there. You can imagine how you will do it. Go, stuck it in, and then put an elbow to it and lock. So the same thing happens with those ventricles. The atrium, when the SA fires, you know what will happen? It would stimulate the right and left atrium, which will then contract, pushing the last third filled up to look at it. So you'll force blood in. When you force blood in, it will get in because the ventricles will give in, expand a little bit, okay? But then it will contract because of the force of the blood you're pushing in. When it contracts, it actually will close the valves, close the AV valves on the right and left side, okay, because of the pressure of the blood inside the ventricles. When they close, the right and left AV valves, when they close, this produces the first heart sound, S1, which is the lub. I repeat, when blood was pushed into the ventricles, and then the ventricles expanded a little bit, stretched, and then rebounded to push back because of the blood force into it, it made the valves close behind them. This is the atrioventricular valves on the right and the right atrium, right ventricle, left atrium, left ventricles. Those valves, the tricuspid and the bicuspid, they shut behind them because blood pushed them close. That shutting of the valves, that makes a heart sound, the lub. That makes the first heart sound, lub. Okay, so now you have the valves closed, the aortic and pulmonary still closed. You now have the end of relaxation. Remember, we were all relaxing. These ventricles were relaxing all the time that it's being filled up. So this is the end of diastole, the end of relaxation. Therefore, we call this actual state, right, your end diastolic volume. This is the volume at the end of resting, diastole. Right? And you could imagine it's filled up. Okay? Now, the next thing that would happen here is, remember the SA node fired, right? So then after firing, it will send its signal to the AV node. And the AV node delays a little bit. That's when we allow more of the, probably the third fill coming in, right? So we can tighten up the volume of the ventricles. But the AV node picked the signal up, and now it's sent into the bundle branches, and the bundle branches sent into the Purkinje fibers, which is embedded in your ventricles. At which point, it goes right on timing that now we need the ventricles to contract. The volume is isovolumetric. Nothing is coming in, nothing is coming out. We already shut the AV valves closed. This is an isovolumetric condition. Now, when you make the ventricles contract, you will try to squeeze and make the volume smaller, the size, I mean, the chamber of the ventricles, the size. And when you do that, you increase the pressure. Why do we increase the pressure? Because if you just push and let the blood out, that's not even going to make it to the other organs that you have, because there's low pressure. We don't release the blood until such time that the pressure is high. Remember, we contract, but we don't release. We contract, continuously contracting, and this happens real quick, less than a second, forcefully contracting, because the Purkinje fiber stimulated the ventricles, the cardiac muscles of the ventricles. So they will contract, huh? Ringing upon themselves. Remember the ringing towel? Ringing upon themselves, and they will reach a certain pressure where that viable pressure, the pulmonary valve will open and let that pressure run through the pulmonary trunk so it reaches the lungs. The aortic valve will also open, and because the ventricles on the left are stronger and thicker, would have a stronger pressure, which is needed to push all the blood throughout the circulation. Right? At this point, you release the pressure from the ventricles. You're now in contraction, right? You are in systole. Okay? You are in systole. So what would happen now is the blood will rush through and go to the two main vessels, pulmonary trunk and fall back, right? Will fall back and it will close the pulmonary and aortic valve. This closure makes the second heart sound, right? This is dub. So when you hear in your stethoscope, listening to your patient's heart, you hear lub dub, lub dub, lub dub. Well, what happened was when you hear the first lub, the second, third fill has already been done, and the ventricle so full, and then it started to contract. And before you could even think dub as the second heart sound, the blood has been pushed out. You have reached that pressure already, and the blood's been pushed out. The blood now falls back on the valves, creating the dub. The whole thing happened between lub dub, lub dub, lub dub. The whole thing that we tried to imagine and understand. Okay. Again, and then this time I will refer to the picture so you can now follow me. So here you are. First, we have contraction, and at this point, the ventricles have just contracted. So they are in diastole. Next thing is the atrium, which has been by themselves, not involved in the ventricular contraction, has been filled with blood, huh? Flowing from the vena cava, and this one flowing from the pulmonary veins. Rapid flows in, flows in. The second would be uh, slow fill, which because the blood is still continuously flowing, it will still push in some more blood. And then the third would be and because it's a lot, it pushed the ventricle wall, which allowed the incoming last third of the blood. And once it followed inside, the pressure itself closed the valves behind them. Huh? So this closed the AV valves between the right atrium sound lub. This at this point is the final volume of diastole. So we call it end diastolic volume. This is a condition where there's no blood coming out, there's no blood coming in all valves. So this is the same volume. So we call it isovolumetric condition. The SA node has fired earlier and has sent the signal to the AV node, which sent the signal to the has fired earlier, sent it to the AV node. It also sent a signal down the um, to the Purkinje fibers, which stimulates the muscles of the ventricle. So what would happen after this has been filled? Okay, remember we just had the first heart sound. It's a combination between the two valves, lub. The ventricles will now contract because it's being stimulated by the Purkinje fibers. Now you will be in isovolumetric contraction. Nothing changes. We're trying to increase the pressure by not changing anything inside. Volume does not increase. Now, this will increase the pressure because we're trying to squeeze it to a smaller volume. We wait, okay, until we reach a good high pressure. The pulmonary valves open, allowing blood to go into the pulmonary artery on the way to the lungs, and the aorta or aortic valve also open, allowing to now flow into the aorta. When all this blood has gone to the next phase, to the next area, you now have these vessels full of blood, and actually it will fall back and cause the valves to shut. Aortic valve will also shut close because blood here actually fall back on the valves. This will create the second heart sound. So from the lub, lub, dub, lub, dub, lub, dub, the whole thing has happened. Okay? First there's filling, first, second, third, then lub, then we contract, release, and then it goes dub. Okay? Lub, contract, release, dub. Lub, contract, dub. Lub, dub. Lub, dub. Lub, dub. Lub, dub. See? Less than a second it happened. And you are at the resting position. You are sitting down. When you start to round, guess what? This will all happen, but in a faster faster tempo. So it'll be lub dub 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 lub dub. The whole thing happening faster. Lub dub 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 lub dub. And if you start running, rushing, because you'll be learning anatomy, it goes lub dub 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 dub. Does it fail? No, it's working and it is compensating for what you wanted to do. See how amazing this heart is, how amazing this organ is. All right. And it's continuously going to do that until you change phase and you slow down. It's going to go down to lub dub, lub dub, lub dub, lub dub again. See? Very, very intriguing and amazing. I'm going to add some things to this. Again, lub dub is the first and second heart sound. So first heart sound, we call this S1. Second heart sound, we call it S2. Okay? S1, S2. Some make a second sound S3, especially when blood passes through these big vessels, making a whirling sound because of the pressure. That be taken as S3. There's an S4 when you pass through smaller, older, that echoey sound, huh? So there you go. It's important that you listen to what I explained and remember it for how it worked, huh? It will not change. Our hearts have been working like that for hundreds of years. So once you listen to it and it's just it. But I need you to keep on repeating to yourself how it all happened, huh? First fill, second a rapid fill, slow fill, pressurized fill because the atria has contracted. The SA node has fired, right? Which made the atria contract. By the way, the SA node firing means you already picked up a P wave on the EKG. And when the AV node picked up the signal, sent it to the bundled branches into the Purkinje fibers, the ventricles contracted, you see QRS complex, right? And therefore this will contract, contract, contract. First heart sound has been made, S1, the lub, contract, contract, release blood, and then it falls back on these valves, dub, okay? So you now have the second heart sound, and you are now in ventricles are now back to relaxation because they just contracted. They went into systole, now they're back in diastole. And if you notice, they're back in diastole, no changes, nothing coming through there, nothing coming through here. Another isovolumetric condition, but this time of a lesser volume. This is during relaxation. Okay, what happens after this is we go back to step one, wherein rapid fill comes again, slow fill, and then your SA nodes stimulating the atria, pushing more blood in, and you're back to the same sequence. So in reality, this is happening on both sides. Pressure, pressure, fill, fill, pressure, pressure, push, push. Pressure, pressure, fill, fill, pressure, pressure, push out, push out. Okay? All right. Now, adding also, let's talk about the what ifs. What ifs, okay? This is all good and dandy. But what if? What if the valves actually are not perfectly closing? What if the valves are not? Let me see if this goes back. Oops, wait a minute. Then you will have some problem because if they do not completely close, then blood will leak. Okay, and we call that valvular insufficiency or incompetence. Any failure of a valve to prevent reflux, then you will have a backward flow of blood. It will make a murmuring sound, which is termed as heart murmur. It would be like water escaping through a leak, something like that, heart murmur. When the valves are hardened or stenotic, this can stiffen and the opening can be okay, constricted by a scar tissue. Sometimes this is because of a previous inflammation, like in rheumatic heart fever, when your immune cells attack the valves, thinking that they are made of or foreign. There's an M protein in them that the white blood cells get attracted to and think that it's foreign, so they hit on it. So eventually they damage their own valves. Okay. So when you hear lub dub, lub dub, if you hear the murmur in between them, like lub sh dub, then that's a systolic murmur. Happens during systole. But if you hear, how about when you hear a diastolic murmur? How would that sound? Okay. All right. Try it. Okay. All right. So remember, begin with sound, lub dub, lub dub, lub dub. Systole, diastole, systole, diastole, systole, diastole, right? So if it's a diastolic murmur, it would sound like first it's lub dub, lub dub, lub dub. Now the murmur comes in. Lub dub shh, lub dub shh, lub dub shh. Happens after the diastole. Systolic, diastolic, systolic, diastolic, then murmur. Lub dub shh, lub dub shh. That's how it's gonna sound. Okay? All right. Very interesting. Mitral valve prolapse is common in a way, and we call this MVP, not most valuable player, but mitral valve prolapse. It can also be one that's not have a major situation that a person can live life through that, but they will short to when it actually gets overloaded. This is also hereditary, 1 out of 40 people. Auscultation is fulfilling your need to hear it, so your sense of hearing, listening to the sounds made by the body. And like we said, we have the first and second heart sound, lub dub, huh? And okay, and let me just get the next slide, if I may. Okay, same thing, huh? when we when we were filled up, okay, let's go to the point where the ventricles are all filled up. Okay, ventricles are all. When the ventricles contracted, it will keep the volume closed first, contract, and then push blood out of it. It will actually push out a certain amount of blood from the ventricles. This amount of blood that push out, which is the blood that falls back on the valves when it's pushed through the pulmonary and aorta, pulmonary trunk and aorta. This is your ejection. This is what this is actually called systolic volume, which is what's being pushed out. Oh no, I'm sorry, stroke volume. Every stroke or contraction, this is the volume that goes out. Okay, so we call it stroke volume. The ejection is basically what's being pushed out. The same thing. It's also basically the stroke volume. But if you get the ejection fraction, the ejection being the volume stroked out, you will then divide the because the full maximum volume is 130 and you pushed out 70. So divide 70 by 130, okay, you get 0.54, meaning the 70 that went out is 54% of 130, which is what the ventricles would have had at full end diastolic volume. Okay, so that's your ejection. The percentage of blood that was ejected out, which is a stroke volume, with respect to the original volume of the ventricles. Huh? All right, good. Let's go ahead and put some math to this. I just want to read this real quick. In a resting person, atrial contraction lasts about zero point 0.1 seconds. Ventricular contraction about zero point 0.3. When all chambers are closed, about zero point 0.4 seconds. The total duration of the cardiac cycle, contraction, relaxation, systole, diastole is zero point 0.8 seconds when the heartbeat is 75. If it's lower, then um, it may be longer. But if it's higher, it may be faster because we'll cope up. Huh? Still depends. This diagram, Wigger's diagram, also corresponds to what we discussed. Look, this is the volume in the ventricles during ventricular relaxation, diastole, empty. Here's see how if this means it's an increase in volume, see how much it increased. And this is fill. First, remember the first third, and then this is the second fill, slow fill, and then what did we say? We said the SA node fired, right? And look what we have here, the P wave, which caught the SA node electrically. Huh? So therefore, it will make the atrium contract, and look, it pushed some more blood in the ventricles. This here is the ventricular volume part of the graph, which makes sense because that push is actually because of the Purkinje fibers manifested by QRS complex. It ties up. This Wigner's diagram is a occurs. It happens. So now you got full isometric condition, and then because of the contraction, we increase the pressure, but we're not changing any volume inside. We just make any amount. I mean, huh? No change in amount, isovolumetric. But we just change the shape to squeeze it. And look at this sort of length of a segment here. That's when you don't allow anything going out or in of the ventricles, no blood coming in or being added or taken out. This is isovolumetric contraction, which at a certain pressure, look what happens, we release the blood, and therefore you will have less blood in the ventricles. It goes down in volume, see? And this relaxation of the ventricles is also manifested by the T wave. See all these things, happening, okay? The way we describe it and the way we understood it. Every time you see this, you can always play around with it and try to follow the way the sequences happen. Okay, so let's go ahead and put some numbers so we can easily understand it. Oh, I'll probably give another view of it. So ventricles are relaxed, okay? This is your end systolic volume. About 60 ml is left. There's still blood left after ventricular contraction. And then we add the first, second fill. Rapid fill, slow fill gives us 30 ml. And then we added when the SA node fired, making the atria contract, push another 40 inside the ventricles, okay? At this point, you have 130 and the ventricles are filled. It shut the valves behind it. You got S1, and then finally blood was let out, okay? And the blood that was let out was 70 ml, okay? 70 ml. Then the same blood or whatever's left of it went back and closed the valves behind them, creating the second heart sound. And at that time, nothing leaves or is added to the ventricles that have just contracted. So you're now in diastole. And here you have the blood left over, which is 60. And if you notice, we're back to the beginning. We're at 60. We start to add rapid fill, slow fill again. And then atrial full volume of ventricles again, and diastolic volume. And then we contract, systole, 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 finally releasing. We push out -70 again. Our at the same time. It's cold. And now we have this is your end systolic volume. What's left at the end of contraction. If you have an end diastolic volume, you also have an end systolic volume at the end of the contraction. Okay? All right, very good. Now, I will do the what ifs. You know the what ifs, huh? What if, okay, what if you have a congestion happening, okay? Normally, the right and left sides of the heart eject at the same time, right? Even under different pressures. Atrium, ventricles contract. Atrium contract, ventricles contract. Right and left contract, right and left ventricles also contract. But what if one of the ventricles, okay, let's say the left ventricle happens to be weak. Oh, I have a picture. Okay, I'm gonna use this for now, huh? Mm, what if the ventricle is weak, huh? Let's say the left ventricle is weak. So when it tries to contract, okay, when it tries to contract, it's supposed to push out a certain amount of blood, right? It's supposed to push out probably the 70 ml. But because it's weak, it's only able to push out 65. It's weak. So what's going to happen to the 5 that did not get to be pushed out? It stays back in the ventricles. So instead of 60 as your end systolic volume, you have an extra 5. Because remember, it was too weak. This is the left ventricle, okay? For example. And so this is happening many times in a minute, right? 75 beats per minute. And I'm just exaggerating on the 5 ml. This is really catastrophic at that level. Usually about less than a ml or 1. So every time there's a contraction, you have a leftover amount of blood. What will happen is you will accumulate leftover amount of blood in the left ventricle, and eventually you will increase in volume of leftover. When the left atrium delivers its next volume over now a half filled, your ventricle is going to work harder. And remember, it's weak to begin with. That's why it's not able to push complete 70. So now it becomes even more weaker and weaker and weaker. Because every time there's always an added volume. What would happen is your ventricles will now backflow to the next chamber, which is the left atrium. See? This will backflow in the left ventricle because of the leftover blood. It will fall back on the left atrium, and guess what? It will backflow into the pulmonary veins. And if you're following my idea, if it backflows in the pulmonary vein, guess what? It backflows into the lungs. Into the lungs, it backflows. You have blood not making it and backing up, right, into the lungs. It's like if you had a problem with your water closet or your bowl, if it gets blocked, you will see some symptomatic situation all around the pipeline, the sewage, because it will reflect on other pipes. In the lungs, now, in the lungs, the pulmonary veins are still filled with blood, and new blood is being pushed to exit. You will have a stasis. You will have blood stagnant, almost stagnant, huh? When you have that situation, you will now have two differences of water levels. The blood that's inside the blood vessel has water content, and the blood in the tissue has less water. But because was given a time to almost stand still or slow down, now the osmotic pressures will dominate. The water from the blood vessel will now go to the area where there's less water, which is in the pulmonary tissues. So eventually your patient will develop pulmonary edema. Pulmonary edema. It will be shortness of breath, difficulty of breathing. See, all this started with a left ventricular failure, right? And then it ended up with backing of blood back all the way to the lungs and now creating an edema there, pulmonary edema. Okay? Can it happen to the right side? Yes, it can happen to the right side. If it happens to the right side and the right ventricle is weak, then it will back up. Ventricles cannot push blood into the lungs. It will back up not towards the lungs, but towards where it came from, which is in the veins. And in the veins, you will have varicosities, you will have stagnation of flow. The water will now leave from the vessels into your peripheral edema, a peripheral area, and cause peripheral edema. All right, see? Again, the same situation, osmosis. Where there's a lot of fluid, it goes to the area of less fluid or water. So the bottom line is if you have left ventricular failure, the manifestation is pulmonary edema, backwards. Right ventricular failure manifestation is peripheral edema. Okay? This is in congestive heart failure. Huh? We sometimes give the digoxin here because actually it's a good mainstay because it helps to control the strength of contraction. Okay, there you go. Now, let's put it on the other side. For example, we were talking about weak ventricles. How about if you have, so we were talking about weak ventricles, right? Again, the bottom line is if you have a weak left ventricle, you'll end up with pulmonary edema. If you have a weak right ventricle, it will back up all the way to the extremities, the intestines. You will have ascites, you will have peripheral edema. See? So that's the bottom line, huh? Now, let's turn the table. Instead of weak, failing hearts, let's consider a heart that is overpowerful. Overpowerful, huh? So now, let us check this out. What if the left ventricle, well, no, let's start with the right. This is right ventricle is too powerful, therefore pushing blood really strongly into the lungs. And when you push it strongly, that means you have a lot of blood going there and maybe too much for the pulmonary vein to evacuate to deliver to the heart. So what would happen? You again will have engorged vessels in the lungs. And when you see engorged vessels where there's more water inside the vessels than it is in the lung tissue, it will attract the water to go down to the lung tissue, out to the lung tissue, and it will stay there, creating pulmonary edema. So this time, pulmonary edema was created not because of backflow, but actually a forward flow, because the right ventricle is this time too powerful, not like the left ventricle that's weak. So pulmonary edema in an overpowerful ventricle can be caused by right ventricular overpowerful contraction. Okay. Now, how about the left? If the left is overpowerful, okay, what would happen is it will push blood. Let's take the next picture here. It will push blood from the left into the aorta and into the systemic circulation. Because it's overpowerful, you get more blood in the systemic circulation. Too much for the venous side to pull back towards the right side of the heart. So now your blood will accumulate. And if it accumulates in the peripheral, you'll have edema in the peripheral. Same situation. More water inside the vessel this time. There's too much blood in the peripheral, and therefore it will leak into the water will leak out of that into the tissues, causing edema, peripheral edema. Okay, there you go, huh? See, because we know the basic mechanism of the heart, we can now apply some conditions. Okay. About cardiac output, abbreviation again, CO, cardiac output. It's the amount of blood ejected, but within 1 minute. Excuse me. So if you had 70 ml, multiply that. Uh, how many of that 70 ml is pushed out in a minute? That's your complete cardiac output. So in a mathematical equation, cardiac output is the heart rate times the stroke volume. Heart rate times the stroke volume. If you increase the heart rate, your cardiac output will increase. If you increase the stroke volume, your cardiac output will increase. So in essence, if the heart is weak, but it has to maintain a cardiac output, the heart rate will increase. So all the more it makes it worse, right? If the heart rate is, for example, weak, then we have to increase the stroke volume. Although it's a slow rate, there's a huge amount being pushed to maintain the cardiac output. Okay, cardiac output is normal at 4 to 6 liters per minute at rest. Imagine a red blood cell leaving the left ventricle. Okay, we'll go to the aorta, systemic circulation. We go to the capillary. We'll go back to the right side into the small veins, medium-sized veins, large-sized veins like your vena cava, inferior or superior, and it goes back to the pulmonary circuit until it reaches the left atrium, back to the left ventricle. Guess what? How long it took? It took about a minute. It took about a minute. Red blood cell leaving the ventricle, coming back to the left ventricle, about a minute. See? And this is continuous. There's no air gap. There's always continuous blood in front and blood at the back. Right? Very interesting. Vigorous exercise can increase cardiac output from 4 to 6 liters to about 21 liters per minute. And maybe 35 for really a professional athlete. All right. Now, as we push blood out of the ventricles into the aorta, this pushes blood that's previously in the aorta forward to the next blood vessel. And this pressure is your heartbeat. Heartbeat. You can feel this in the radial pulse. You can feel this in the inguinal groin, inguinal artery, a femoral artery. And you can feel this behind the knee, popliteal, and in the ankle dorsalis pedis. You can feel this in the apical beat, and you can feel this in the carotids. Okay. Infants, remember, are not happy with 80 beats per minute, which is happy for adults. It's actually 120 beats per minute. Okay. So that's the minimum. The maximum is 160 beats per minute. So an infant is between 120 to 160 per minute. They're happy. Nothing wrong. Okay? Increased heart rate, tachycardia, and these are the reasons that may result into that condition. Bradycardia is when you are slower in heartbeat. Chrono means time. So when you say chronotropic, increases, increases the rate. So positive chronotropic agent increase the rate of the heart. Negative chronotropic increases the rate or the time. So it's negative chronotropic agents. So these are agents that increase the rate, increase or decrease the rate. Now, the somewhere here is the chrono. If chrono is time, ino is contraction. If you want more contraction, you give a positive inotropic agent. And if you want less contraction, a negative inotropic agent. Okay? Cardiac ANS here. The autonomic nervous system does not initiate the heartbeat. It modulates the rhythm and the force. There's cardiac centers in the reticular formation from the medulla oblongata. Has cardiostimulatory and cardioinhibitory neurons or effect. Because of this, it manages to help with the heart rate. Again, sympathetic fibers are adrenergic. They have norepinephrine. They activate second messenger and lead to opening of calcium when needed in the membrane. So sympathetic is for increasing heart rate, which it needs when it is on a mission, right? When the body is in a mission. So therefore, it will increase the heart rate. Now, the parasympathetic is by way of the vagus nerve, okay, basically also from the medulla oblongata, and it will have inhibitory effects on the SA and the AV nodes. We use acetylcholine, and the heart slows down. Without influence of the cardiac centers, the heart has a firing rate of 100. But the vagal tone, which is constant, makes it go down smaller. So to begin with, we are high in our heart rate, but the vagus throws a certain tone or influence, bringing it down to 70 or 80 beats per minute. Okay. Inputs to the cardiac centers in the medulla are diverse. Some are from the brain centers, some are from the limbic emotional, because it will change depending on the emotion, and some come from the proprioceptors. Pressure from the vessels all around it, carotids in the aorta, will also change the situation of the heart rate. If the blood pressure decreases, the signal drops, cardiac center increases heart rate. If the blood pressure increases, signal rates rise also, cardiac center decreases the heart rate. Chemoreceptors are measurements of the chemical stability of the blood, right? pH, oxygen, carbon dioxide level. Together with the reflexes, they respond to fluctuations in blood pressure and chemistry in a negative feedback loop. Autonomic nervous system or works in through the neurotransmitters, norepinephrine and acetylcholine. Okay. Nicotine stimulates catecholamine secretion. Thyroid hormones increases the number of adrenergic receptors. That's why it's more responsive to adrenergic stimulation. Caffeine inhibits cyclic aminophosphate. Electrolytes, big time. Potassium, right, can lead into hyperkalemia, which makes it worse, and also hypokalemia when we don't have it, right? Hypokalemia when you have a deficiency in potassium. Increased calcium is hypercalcemia, which decreases heart rate and contraction, where hypocalcemia increases heart rate and contraction. Okay. Stroke volume is SV, but it's affected by preload, contractility, and afterload. Let's define this. Okay. Preload is basically the amount of tension that the ventricles already have. Preload is basically the 60 ml that's left behind after systolic contraction, right? So if you increase the preload, it will increase the force of contraction. Exercise increases venous return, so that's why it ends up increasing everything. But whatever is left there before contraction during ventricular diastole is preload. Again, Frank Starling law says the more you push the ventricles, the more they push out, and which makes us maintain our blood status even if we are slowing down or asleep, right? So it matches it wonderfully. Contractility refers to how hard the myocardium contracts for a given load. There are contraction here, so what we need are inotropic agents. Inotropic agents are agents that cause increased contraction. There are positive, which increases contraction, and there are negative. Hypercalcemia, catecholamines, epinephrine, norepinephrine, glucagon, digitalis all raise contraction of the muscles. All raise contraction, not the rate, but just the contraction strength. Negative reduces contraction. Low calcium levels will do that. Increased calcium, potassium will do that. Vagus nerve dominating the picture will also do the slowing down of contraction. So that's your preload. and then you had your contraction. The next is afterload. What is afterload? Remember that the ventricles are loaded up and they will try to contract until a certain right pressure. When the pressure is reached, they push blood into the pulmonary trunk and blood into the aorta. But you know there's blood there previously. So now your new load will push against the blood that's in there. And then you're talking about the blood all the way to the lungs, and on the aortic side, blood all the way to the circulatory system. That's a lot of blood to push, right? So that's how strong the pressure should be. Okay? Then that blood, which is already in the pulmonary trunk and aorta, is blood that's easy to that can be pushed by the heart with this new blood. Huh? But if there are pressures after this aorta, which is high blood pressure, then you're pushing against a stronger pressure higher than normal. Okay? The afterload is the pressure by the blood in the pulmonary trunk and the aorta, which is what the blood in the ventricles will have to face moving forward. So that's the afterload. Right. Hypertension is afterload, like I said, huh? Okay. Exercise also as a factor to consider because when you start exercising, the proprioceptors, which measures movement in your muscles, in your tendons and limbs, will send signals to the brain and say, "Hey, we got activity here." So the brain will now move into go mode or the sympathetic mode and increase cardiac output because it knows the body would ask for more blood in the muscles. Increased muscular activity will also increase venous return. So the preload, the blood in the ventricles, will increase. And Frank Starling said, "You increase it, I will give you an equivalent push." Increase in heart rate and stroke volume causes increase in cardiac output, if you remember the formula. Exercises produce ventricular hypertrophy. When you work uh, a body part many times strongly, you actually, like in working out, huh? In working out, the muscle cells increase in size. If it's in size, then you call it hypertrophy, and therefore the muscle grows bigger. If it's, for example, um, what's a good example? Scar tissue. If you had an injury and scar tissue will form, and you had an excess scar, okay, excess scar, which is like what we call keloid, then you had a hyperplasia. Plasia is not the size, but the number of cells increased. Okay, we call it hyperplasia. Again, hypertrophy is increase in the size, hyperplasia is increase in the number. So an athlete sometimes can develop ventricular hypertrophy. Increased stroke volume allows the heart to beat more slowly at rest. So because the ventricles have been trained to push hard, they have increased in size. So they, with just one contraction from them, they already fulfill the amount of pressure that's expected in the circulation. They actually don't have to pump so many times. Sometimes they only pump 55 beats per minute, and the person is alive and okay. And even sometimes 50 beats per minute, right? Again, these athletes have now stronger, thicker muscles of the heart that they can really push hard, and they don't have to make it many times, increase the number of, or the heart rate, because a good push by the strong ventricles is enough. It's enough to maintain that pressure. Now, it is also a fact that uh, the the other side of it is there will be conditions where an athlete who is so driven might over-exercise and make the heart increase in size. Right? There'll be an enlargement, and the ventricles can be thicker because of the excessive exercise or routine that he makes. Sometimes this would be an athlete playing tennis in the middle of an important game, and then at the peak of his game, suddenly collapse on the floor, and the heart failed. See, this is when hypertrophic myocard no cardiomyopathy, hypertrophic cardiomyopathy. Young athletes who has overworked their heart will now find the peak moment when the heart fails to deliver and will result in a heart attack. Okay. There are also conditions like diseases of the coronary arteries, which will end up in constriction, plaque, uh, fats from the cholesterol, rather, or lipid from the digestive system is absorbed through the lymphatic. From the lymphatic, it reaches the circulatory system. It doesn't go to the liver first by the uh, portal vein, hepatic portal vein. It bypasses it. So it reaches the circulatory system earlier and it can start some diseases, which is coronary artery diseases if it's atherosclerotic plaque. Okay. The endothelium can also be damaged and can, by hypertension, diabetes, or other causes, resulting in further damage of the blood vessel. Okay, again, your own cells could also be a factor why there is uh, damage in the system. Angina pectoris, which is will produce intermittent chest pain also. Huh? Immune cells of atheroma can stimulate inflammation. Coronary arteries can go in spasm because of the lack of nitric oxide. And inflammation can transform an atheroma into a complicated plaque. Risk factors for CAD is low density lipoprotein being high, and then the receptors are not functioning. The low density lipoprotein, right, can accumulate and begin to have problems with atherosclerotic plaque. Dysfunctional receptors can cause them to accumulate, and therefore you have a high cholesterol level. Risk factors that can affect or reduce coronary artery disease: heredity from the family line, aging, male is also prone to that. Risk factors that can be avoided or preventable: obesity, smoking, lack of exercise, anxious personality, stress, aggression, and diet. Coronary bypass graft is a good option, and we call it cabbage. Huh? Coronary, there should be an artery here. Coronary artery bypass graft, cabbage. Uses the great saphenous vein in the lower leg, all thoracic artery to supply, huh? Make a new uh, vessel supporting the muscles of the heart. The old one had plaque in it, like obstructive atherosclerotic plaque. Treatment, another treatment. By the way, they also use mammary artery in another specialized procedure, huh? You would see people who had this cabbage, coronary artery bypass graft, have some scar mark in their lower leg. That's where you can harvest the great saphenous vein. And we use it to bypass an old vessel, and so therefore be able to bring blood into the ventricles and atrium or any heart part, because now the blood vessel is not blocked. Balloon or laser angioplasty can also be used, huh, to widen up the blood vessels. There can be a good number of applications for it. With a stent also to prevent caving in. Right? All these can be done in order to um, maintain, huh, maintain the function of the heart. All right, that concludes our chapter 19. I hope you enjoyed it. It's a very important chapter, very good to know. And if you understood my lecture, well and good. You can keep on imagining it again and again how it happened, and it will stay in your memory. And no matter what the topic is, if it's about the heart, you can understand. If it's about medication applied to the heart, just know what the medication is for. Is it increasing, decreasing heart rate, or heart contraction? Then you know what's happening and what's going to happen. Okay? All right, let's throw some quick questions, huh? Quick questions. Let me know what your answer is. Tell me if it's oxygenated or deoxygenated blood that's in this part of the heart. Okay, you ready? All right, let's go for right atrium. Do you have oxygenated or deoxygenated blood? Okay, right atrium will have deox blood. How about left ventricle? Deox or oxygenated? Oxygenated. How about your pulmonary artery? Coming from your pulmonary trunk going to your lungs, it is deoxygenated. Your pulmonary vein has oxygenated. By the way, let me remind you again, you might be thinking, if the pulmonary artery is carrying deoxygenated blood, how does the lung survive? Well, the pulmonary artery is more of a functional vessel. The vessel that delivers nutrition to the lung is actually the bronchial artery. That's a true artery because it comes from the aorta, which has oxygenated blood. So that's how your lung and your respiratory system is being perfused and nourished. Bronchial artery. It exits through the bronchial vein. Huh? The lung gives off its deoxygenated blood through the bronchial veins. Excellent. All right, next question. If I were in the pulmonary trunk, where will I be next? And you could just fill in the information if you want. A, pulmonary vein. B, pulmonary artery. C, mitral valve. D, semilunar valve. If I am in the pulmonary trunk, where will I be next? It will be, all right, pulmonary artery. Okay. If I am in the pulmonary vein, where have I been? Where have I been? And the answer there would be the lungs, right? If I'm the superior vena cava, where will I be next? And the answer is right atrium. See, it comes from the flow of the heart, blood flow in the heart that we have studied in the beginning. Okay. All right. Question again. Uh, P wave represents what node? P wave represents what node in the EKG? All right. It is the SA node. Right, SA node, P wave. How about what is the gateway to the ventricles? Gateway to the ventricles, SA node or AV node? It is AV node. Okay. Stimulates the ventricles, SA node or Purkinje fibers? SA node or Purkinje fibers? It is Purkinje fibers. Right. Which one has a bigger volume? End diastolic volume or end systolic volume? It is end diastolic volume. What makes up the mitral valve closure? Is it S1 or S2? Mitral valve closure, is it S1 or S2? It is S1. Okay, right. Lub dub, lub dub. Which one makes up the second heart sound? Second heart sound is dub. Okay, there you go. Okay, if the ventricles have leftover blood of 60 and it was able to push out 70, how much was the stroke volume? if the ventricles has leftover blood of 60, which is the end systolic volume, how much was the, and then we pushed out 70 ml. How much was the stroke volume? 70 ml. Okay. The blood pressure, okay, which is the blood pressure which is in the aorta before ventricular contraction is considered as preload or afterload. Preload or afterload. It is afterload. Afterload. The base of the heart, all right, true or false, the base of the heart is the right ventricle because it's sitting on the diaphragm. The base of the heart is the right ventricle because it's sitting on the diaphragm. It is false. The base of the heart is opposite that of the apex, the area of the top part of the heart where the blood vessels are. Okay, right. Now, um, last question, last two questions. Patient has pulmonary edema. Patient has pulmonary edema, and the patient uh, has an overactive ventricle. Question is it the left or right ventricle that's overactive? Again, patient has pulmonary edema, okay, and it's because of the overactive ventricle. Is it the left or the right ventricle? Okay, the answer is an overactive right ventricle. That's pushing too much blood into the lungs, and there's stagnation there. You'll end up with pulmonary edema. Okay? All right, very good. I hope you enjoyed that. Read some more or anything, any news about the heart, anything you catch up in social media or your cell phones. Go ahead and read it and try to recall what you understood as our basic anatomical, physiological knowledge of the heart from this lecture, and you will enjoy it. Okay? All right. Um, Go ahead and finish your responses. And don't forget, today is the last day for the assignments. I believe today, right? If not today, is Saturday, I believe, for the assignments um, to have extra credit. The final assignments are due Sunday. The lab quiz, week 2 lab quiz, is supposed to be due Saturday, so you can program yourself to just finish the week 2 exams on Sunday, okay? And therefore, uh, be able to address it properly, huh? Don't forget, if you have time, make the weekly summaries because that's ending up extra points in the end, huh? All right. So again, the assignment is illustration of the heart and the respiratory system, and finding 5 friends of yours, asking for their blood type, and then analyzing what blood types they can donate to and what blood types they can receive from. Huh? Each one of these 5 persons that you ask. That should be emailed or texted to me by picture. That's fine. And that constitutes your makeup or your assignment. Huh? Again, the good thing about this is um, the makeup quiz, which is the result of the assignment, is matched with the other weekly lab quizzes, and then we just get the top 4. See? So it can really help a lot in the average. I will also say in advance that we are moving into the 3rd week, and the 3rd week is this coming week. Then we have the 4th week, okay, the 4th week. that would be the time of July 4th. If I believe that is on a Friday, July 4th is on a Friday. The university is closed on a Friday. So what it seems to be is the last day may be July 3. And that's to let you know ahead. The last day ends up July 3. So we will have to adjust and adapt to that situation. Okay? That's to let you know. Okay, but I will do that. I will announce that also, huh? I'll announce that also next week. Okay, so uh, I'm closing this so you can listen to it. The machine, the system will buffer it and deliver it for your review, huh? Thank you so much. Have a good night, and I will monitor your development on my side.